elective, or is it urgent, or is it emergency, like in type A dissection, or salvage, as the patient is having external cardiac massage, an example. So the LV function, is it above 51%, or is it moderate if it's 31 to 50? It's poor from 21 to 30, or very poor if it's less than 20%. And as we say, the weight for the procedure, is it a single procedure, or like an example, CABG plus aortic valve replacement, or MVR, or replacement of the ascending aorta with aortic valve? So as we see in this slide, this is the calculator of the Euroscore 2. You will put the variable and the risk factor of your patient. Then it will give you a percentage. If it's above 20%, it will consider a high. If it's less, no. Then we'll move to the STS algorithm. Uh, The State of Thoracic Cardiac Surgery National Cardiac Database was created in 1989. The primary aim of the models is to support the National Quality Improvement Program, and the data were collected prospectively from more than 950 participating centers in United States. And the predictive performance of STS algorithm is generally comparable with other systems and remain most widely used in the United States. And it usually including the procedure with it as the same for you too, like an isolated cabbage. Is it isolated valve procedure, or is it isolated valve procedure plus cabbage? And the operative mortality was found to be greatest with the following risk factor. Is it the salvage status, an example of external cardiac massage, or a patient with end-stage renal failure, or the emergency status, or multiple reoperation like in redos, or a patient with severe symptomatic cardiac disease and with New York Heart Association class 4. And there are three ways to obtain the STS score, either from the STS approved software, or by using the online STS calculator for one patient at a time, like we will show in the next slide. It's a similar calculator. You will add your patient variable and risk factor, and it will give you a score. And if it's above 10%, that consider significant or a high risk. Finally, is the Barsonet score, which is a more simple score, which is developed in 1989. And in this score, it's more simple score. You have risk factor, and each risk factor has a number of points. At the end, you will calculate these points, and you will apply it at this score. And when we have 0 to 4 score, that's it. That means good. If it's with a predicted mortality of 1%, if it's 5 to 9, that carry mortality of 5%. If it's 10 to 14, it's with the predicted mortality of 9%. If it's 15 to 19, that mortality risk is 17%. If it's 20 or more, that's considered extremely high with 30% and above mortality rates. Thank you. This is what was my lecture.
Thank you, Faisal. This was a very nice overview and summary for the preoperative care and risk stratification assessment for our patient, which is integral part of our daily practice in cardiac surgery. Any comments or questions from the group to Dr. Faisal?
Just one addition, since I like using this risk scores. Sometimes you wonder what risk score you can use for each patient. Just if you ever use the STS risk score, you notice that they limit you in the type of procedures that you're going to be using. You're either going to be risk stratification, you're doing the risk stratification for CABG patient, valve, or I think aortic cases, aortic ascending aorta. But if you use the Euro score, they don't limit you with the procedure. So if you have a procedure that is not included in the STS, usually you have to end up using the Euro score. Otherwise, you can just use the STS.
Definitely, Waleed. It's not for every single case that we do in cardiac surgery, and it does not include also all the important risk stratification risk factors that we encounter in our patients. For example, patient with liver failure or child's B score or child C, you will not see those kind of patient listed in the either STS or Euro score, which I strongly believe it does increase the morbidity and mortality for those patients. But it's a good tool to have it and practice it and using the number and the number when talking to your patient and counsel them and consent them for surgery. Any other question or comments from the group? Okay, thank you, Faisal, again for this nice summary. There's no more questions or comments. We'll move to a few MCQs on the preoperative care, and then we'll move to. So our session today is all about the perioperative care, pre-op and post-op. So we'll start with the first lecture quiz. We have 8 MCQs. Can I have your time reading them and answering them? Okay. Now I guess everyone can see the quiz result and review. We can go through the questions and review them one by one. Any volunteer would like to read the first question?
أيوة خالد.
Okay, go ahead.
Yeah, it's about the معلش أنا شلت الأسئلة لأنه ما عرفت أفتح المايك بس it's about the administration of antibiotic. So it should be like less than an hour. So within half an hour they give the antibiotic and we start this kind of session.
Yes, that's true. So antibiotic prophylaxis administration should be given half an hour at least prior to skin incision to 1 hour max. So moving to the next question. Any volunteer would like to read and participate?
I can read.
Okay, go ahead, Walid.
How long should an emergent cabbage be delayed after a dose of abciximab? No delay.
I noticed Faisal mentioned in his presentation that abciximab should be held 48 hours prior to surgery. Actually, it's the recommended withdrawal period is 24 hours, but in this scenario, when you have emergency surgery, of course, no delay should happen, and in some reports we can delay up to 12 hours if the situation allows. So no delay or 12 hours delay.
خالد شفتها أنا in one reference it's like الإفكت حقه in more than 24 hours within the effect is more than duration of effect is more than 24 hours and then you discontinue preoperatively within 24 hours. This is for abciximab.
Yes, that's true. But here we're talking about emergency.
The emergency, yeah. عشان إنه 48 hours ولا 24. I mean, and I read it in 24 because the duration of effect is like this. Yeah.
Definitely.
For emergency, yeah, definitely.
Yes.
خالد سويت شير سكرين عشان نشوف الستاتستكس للناس their answers يعني.
Okay.
هذا بس أقصد إنه إذا ودك مثلا تناقش بعض
أيوة.
الأنسس اللي كانت يعني نشوف إيش.
Okay. I still see the quiz review, but I cannot see the statistics.
شايفين يا جماعة السكرين شير اللي أنا مسويه أنا ولا لا؟
Yes, I can see your desktop.
شايفين only the desktop؟
Yep.
ثانية. شكله زوم ما يسمح إنه تشوف اللي جوا زوم. معلش خلاص بقفل.
That's fine. Okay, we can move to question number 3. If any one would like to read and participate. It's easy and straightforward, guys. And you can see the answer. We're here just to review and discuss together if there is any controversial answer or question.
I'll read it and I'll tell you the statistics. So third, the most common complication associated with operating on renal failure patient. Half of the group answered worsening renal failure and the other half answered bleeding.
Okay, so the correct answer is bleeding. We're not here interested in the worsening renal failure. We did not specify renal failure in dialysis or which stage of renal failure. But we all know that those kind of patients, we suffer with them in the bleeding post-operatively, especially with the uremic platelet dysfunction. They have it. We can move now to question number 4. Yeah, now I can see the statistics, Waleed. Thank you. Anyone would like to read question number 4?
خالد ممكن تقرأ السؤال because I lost the poll, right? But I cannot see the question. Because whenever I open my mic, I cannot see the poll.
You can click on more in the site and then quiz result again. It will pop up again.
Yeah, I tried. Yeah, I tried that one, but I couldn't. That's right.
Okay. So the highest risk for CABG is associated with renal failure or preoperative LV dysfunction or emergency surgery or diabetes. Those were the 4 answers. And the correct answer is emergency surgery, of course, comes to the highest risk for surgery. Moving to question number 5, which is a case scenario. Faisal?
Yes, I will read.
Yes, go ahead, please.
This is a 62 years old female with a long history of smoking, present with a chest pain. Welcome revealed that she has a severe coronary artery disease requiring a bypass. Her medical history revealed that she has a left breast cancer followed by reconstruction with a transverse rectus abdominis flap, which of the following conduit will not be used for her for bypass? Which was a left internal mammary artery.
Okay, that's true. Any justification, Faisal?
Yes, this patient has a flap which is sometimes lay on the left mammary artery, and if the patient is receiving radiation, there will be a lot of adhesion, especially when harvesting the lemur.
Okay, the radiation part was not mentioned here in the scenario after her cancer therapy, but in this patient in particular, she was treated with TRAM flap, which is the transverse rectus abdominis flap, and the blood supply for this flap is from the internal mammary artery. That's why you should not use the left internal mammary in this lady. So we can go for other conjugate. Okay, moving to question number 6.
Okay, I will read it. Which of the following is not a risk factor for post-operative delirium? Elderly and Alzheimer, memory impairment, all of them are can lead to post-operative delirium. Female gender is not related.
Okay, usually it's male gender, right?
Yeah.
That's true. Any other volunteer would like to participate? We have 2 more questions to go.
HIT is most commonly associated with thrombosis. يعني the most common one.
Yeah, that's true. The common presentation for it is thrombosis with arterial or venous thrombosis.
Yep.
And last question. Any volunteer?
Yeah. Sorry, go ahead.
And go ahead, please.
Okay. Which of the following factors most increases the incidence of external wound infections most after bilateral mammary usage? The most risk factor is diabetes with uncontrolled, especially if uncontrolled.
Yes, that's true. And 82% of the group had this answer right. Okay. So this was the quiz for the first lecture. Okay. So now I guess Walid will share with us the review for the first lecture, our first presenter. After that, we can start our next and second and third lecture with Dr. Anura for the post-operative care of cardiac surgery patient and late complications after cardiac surgery. We'll start at 2 p.m. inshallah. Dr. Anura, you can prepare your slides while participating in the Okay, I know we're done with the presenter survey. Before moving to the next lecture, I see Dr. Farid Khoguer is with us today. It's our pleasure to have him. Dr. Farid, if you have any comments on the previous lecture on the pre-op assessment for cardiac surgery patient, the risk stratification for our patients.
Thank you, Faisal. I think I thank you, Khalid. Faisal have really did a very good job reviewing the topic. Some of the questions that may pertain to you in real practice, as well as an exam, is when to stop certain medications before surgery. Looking also at the scoring systems, I think you should train yourself from day one. You see the patients going for surgery the next day, practice the Euroscore or the STS score, and discuss it with one of your seniors or one of your consultants. If you do this for every case, by the end of the 7 year, you will master it in many ways. You'll know the different aspect of risk that patients see, and also you may have a feel about how significant that for any particular patients. And if you can use more than one system, it will be also good. For example, if you're doing CABG, yes, you can use the STS, but also practice with the Euroscore tool. Those are the two comments. I have one question for the group, and I think that should pertain to judgment. If you have a patient, let's say, as listed by Faisal, 82 years old, diabetic, and the patient need CABG, so he's definitely is a high risk for many things, including infection and mortality, stroke, etc. The question, if we label this patient as high risk, would you operate on this patient or not? Is this prohibitive for operating on those patients? So once you go over all these risk factors, you should, in your mind, know your limitation as a surgeon. When you graduate, for example, you'll take certain risk, but as you mature into the practice, you may add more and take more risk with other patients. But still, there's always a limit where you should not go beyond. And I encourage you to look at this, decide on it as a novice cardiac surgeon who just graduated, or somebody who has 10 years of experience, or somebody even who has 40 years experience. Which one you would not operate or not admit for surgery? Now, philosophical questions or ethical questions relate to this, and maybe some input from the policy of your institute or the government, where you should not proceed and you may be liable with certain risk numbers. That's it. Thank you very much, Khalid.
Thank you so much, Dr. Farid, for being with us today and for your valuable comments. Okay, with no further delay, we can move to the next lecture with Dr. Noura, discussing the postoperative care of cardiac surgery patient, and the third lecture with the same presenter, and the 8 complications post cardiac surgery, and we'll have our second quiz after the third lecture, inshallah. Okay, go ahead, Dr. Noura.
Assalamu alaikum. Is my slide is clear?
Yes, we can see your slides. Go ahead.
Okay. Assalamu alaikum. Good afternoon, everyone. My name is Noura Al Jazeer. I'm R1 cardiac surgery resident in Prince Sultan Cardiac Center. So today in this presentation, we will be focusing on a critical topic of post-operative care for cardiac surgery patients. During this presentation, inshallah, we will talk about respiratory and cardiovascular support, renal support, neurological support, mediastinal drainage, and post-ICU care and discharge planning. As a brief introduction, post-operative care for cardiac surgery patient is a crucial phase in recovery process that directly impact outcome and long-term health for the patient. After undergoing procedures such as coronary artery bypass grafting, valve placement or repair or other procedure, Patients require careful monitoring and support to prevent complications and ensure optimal health. This stage focusing on close monitoring vital signs, prevent infection, promoting mobility, and managing pain. Immediate post-operative care is a critical phase of post-operative patient. Begins when the patient is transferred from operating room to the ICU. Meticulous transfer of information to ensure quantity of care and the quality by anesthesiologist, surgeon, and ICU staff ensure that the patient monitoring is transferred. Checking that the hemodynamic and ventilatory parameters are acceptable, ensure that the mediastinal drainage are well placed, and then outline the preoperative status of the patient, operative status, and then plan the plan of the admitting team. The achievement of satisfactory hemodynamic performance is a primary objective of post-operative cardiac surgical management. The optimal cardiac function ensures the adequate perfusion and oxygenation of other organ systems and improving the chance for uneventful recovery for the surgery. Even a brief period of cardiac dysfunction can lead to impairment of organ system function and leading to life-threatening condition and complication. Monitoring and assessment of cardiac surgery patient post-operative is a complex, multifaceted process that requires careful and continuous monitoring of hemodynamics, such as arrhythmias, fluid balance, and organ function, and support healing process. For the hemodynamic monitoring, we'll need close monitoring of blood pressure, heart rate, central venous pressure is essential to ensure that the heart is functioning well after the surgery. Arterial cannula, which is monitor intra-arterial pressure and allow more specific measurement and control of blood pressure than non-invasive cuff measurement. It also facilitates frequent arterial blood gases sampling. The central venous catheter, it's not only allow continual measurement of the right atrial pressure, but also act as infusion portion for drugs which cannot be given peripherally, which is allow rapid infusion, and insertion port of pulmonary artery catheter, insertion of transvenous pacing wire. Regarding the pulmonary artery catheter, it's indicated in a patient with a hypoperfusion state, refractory to the first and second line of inotropic support. In a case of patients who have pulmonary hypertension, poor ventricular function, and multi-valve surgery. Cardiac output is a key element of cardiovascular support in post-operative care, including tissue oxygenation and balance between myocardial oxygen and demand. The cardiac output determined by the stroke volume and the heart rate. There are three major determinants of stroke volume, which are preload, afterload, and contractility. The cardiac index is a measure of heart efficiency expressed by the volume of a blood pump per minute per square meter of the body surface. The cardiac index was calculated by dividing the cardiac output over the body surface area, and the normal range of cardiac index is 2.5 to 4 liter per minute per meter square. Low cardiac index indicates heart failure. In a case of high cardiac index, which indicates sepsis and hyperdynamic state. Starting with the preoperative causes of low cardiac output, the first cause we have the previous myocardial infarction causing localized or local hypokinesia, recent myocardial infarction resulting in a global hypokinesia, right or left ventricular systolic or diastolic dysfunction secondary to valvular heart disease or cardiomyopathy. Regarding the intraoperative causes, we have the first cause is a poor myocardial protection, incomplete revascularization during surgery, kinking or occlusion of coronary artery, especially when using, especially if it is not resolved before transfuse. Incomplete repair of valve lesion and hypotension before or after bypass. The post-operative causes include either decrease in contractility, which is include hypoxia, hypercapnia, acidosis, and hyperkalemia. Drugs or medication will include propofol, amiodarone, and beta blocker. Arrhythmia, which is include tachycardia, bradycardia, ventricular arrhythmia in a case of ventricular tachycardia or ventricular fibrillation. The second cause of decrease of cardiac output in post-operative patient and decrease of left ventricle preload is due to hypovolemia in a case of hemorrhage or polyuria. The second cause is a vasodilation in a case of warming, sepsis, or vasodilating drugs such as nitroglyceride, or the right ventricular dysfunction or pulmonary hypertension. In a case of cardiac tamponade, tension pneumothorax, as well, it causes low cardiac output. Sepsis, anaphylactic shock, or adrenal insufficiency may cause also low cardiac output. Increase after load in a case of excessive vasoconstriction, such as in a case of hypothermia or vasoconstriction, or in a case of fluid overload, in a case of valve obstruction, such as mechanical leaflet blockage. Signs of low cardiac output include hypotension when the MAP is less than 60 millimeter mercury, or tachycardia when the heart rate is more than 90 beats per minute, oliguria in a case of decreased urine output less than 1 milli per kg per hour, or metabolic acidosis. Even it includes cold extremities and pulmonary congestion and hypoxia. To assist the patient with a low cardiac output, make sure you know the preoperative history of the patient. Start with the examination. Examine the patient. Start with the chest tube, oxygen saturation, breathing sound, prefer perfusion, and the skin temperature. Reassure that the hemodynamics, such as mean arterial pressure, central venous pressure, and cardiac index are within the normal range. Look at the medication the patient is going on. If the ECG will show any ST segment change, either elevation or depression, heart rate and rhythm, check for the blood gases. Do any if you suspect of pneumothorax or hemothorax, order chest X-ray. In tamponade, the left ventricle and right ventricle dysfunction will we will order echo. After cardiopulmonary bypass, each patient should be monitored with a 12-lead ECG before surgery and daily afterward, alongside intraoperative monitoring for 48 hours post-op. This will facilitate us to early diagnose of ischemia, identify the arrhythmias and conduction defect, detect electrolyte disturbance. For fluid replacement after the cardiopulmonary bypass, patients typically experience total body salt and water overload, which is necessitates diuretics, but several factors can lead to inadequate preload, compression, hemodynamic performance. Regarding the mediastinal and incision bleeding from the surgical site can reduce the effective blood volume. Capillary leak, the systemic inflammatory response of cardiopulmonary bypass can cause interstitial edema. Peripheral vasodilation, such as medication, which is cause peripheral vasodilation in case of propofol or narcotics. Decrease in ventricular compliance this can result in a higher filling pressure at lower intravascular volume, impaired systolic function, transient myocardial depression may require increased preload to sustain stroke volume. Fluid replacement. Most of the patients will require fluid administration to ensure adequate preload and cardiac output. Crystalloid and colloid infusion will help maintenance of intravascular volume, but may also expand to interstitial space. Once hemodynamic stability are well equipped, the capillary leak will resolve. Diuresis can be employed if the patient has excessive salt and water from the surgery and post-op period. Pain management will be by analgesia and sedation if it is not given during operation, which is reduced sympathetic response as a risk for myocardial ischemia, arrhythmia, and improves the patient's respiratory effort and mobilization and physical rehabilitation after the surgery. We will give analgesia as the morphine in small bolus or infusion depending on the age of the patient. We will give acetaminophen. If there is other consideration regarding the management of the patient shivering, we will give meperidine. If the patient has anemia, we will tolerate hematocrit of 22% if a stable patient. For other prophylactic medication such as metoprolol, amiodarone, and are used for atrial fibrillation prophylaxis. Post-operative respiratory care for cardiac surgery patient is the multifaceted process that focused on ensuring adequate oxygenation, preventing of pulmonary complication, and managing the pain, supporting early mobilization for the patient. Ventilation setting. First, we have ventilation in sedation and paralyzed patient is crucial for effective gas exchange and reduce work of a breathing, particularly when pre-oxygenation with 100% of oxygen. The ventilation mode, we will use synchronized intermittent mandatory ventilation is safe for all patients with initial use of pressure control recommended. The tidal volume is maintained in is acceptable and ideal from 8 to 10 milli per kg, which is a prevent atelectasis, but excessive volume can lead to paratrauma and complication with the graft if the patient has CABG. Respiratory rate, generally 8 to 14 breaths per minute is sufficient. In a COPD patient, we have many considerations, but the patient will benefit from lower rates and higher tidal volume to minimize air trapping. Regarding the inhalation-exhalation ratio, is the optimal in 1 to 2 each per minute. The approach to ensure adequate oxygenation while minimizing the risk associated with mechanical ventilation. Pulse oximetry, which is a non-invasive continuous measurement of oxygen saturation, but it may cause error in a case of loss of pulsatile component if the patient if it gives us a false high reading or a false low reading. In a case of jaundice, will give us high false reading, but in a case of carboxyhemoglobin or heavy smoker patient will give us a false high reading. Weaning from ventilation, weaning completed within 6 hours to 12 hours post-op, but patient may poor ventilated function or pulmonary hypertension and surgical problems such as bleeding will take longer time in ventilation. Weaning may cause a vasoconstriction, increase after load and tachycardia, thus increase the myocardial oxygen demand. Criteria for weaning and extubation. First, awake the patient with a stimuli. Even if you call the patient, he will be responsive. Adequate reversal of neuromuscular leakage. Chest tube drainage will be less than 50 milli per hour. Core temperature will be more than 35.5 Celsius. The hemodynamic stability of the patient, blood pressure, heart rate within the normal range, and the cardiac index will be more than 2.2. And satisfactory ABG, atrial blood gases, and a full ventilation. Post-extubation respiratory care for the patient. After extubation, careful monitor the patient. The breathing pattern is essential. Oxygen saturation and hemodynamics is essential. The key consideration here is during monitoring, observe for laryngeal stridor, especially if the patient has difficulty during intubation, which may require epinephrine, steroids, and possible for re-intubation of the patient. Care management for the patient in case of oxygenation, give the patient oxygen mask or nasal cannula to maintain oxygen saturation more than 90%, and consider high flow nasal cannula or mask for borderline hypoxemia or hypercapnic patient. For pain management, give acetaminophen to minimize sedation and improve outcome of the patient. If there is any pleural effusion or any difficulty with the breathing, order chest X-ray, and encourage use of an incentive spirometry and deep breathe every 1 to 2 hours, and utilize cuff pillows with a comfort. Encourage the patient as soon as possible to be mobilized and use comprehensive stocking for VTE prophylaxis. If the patient high risk, give him subcutaneous heparin. For fluid management, initiate diuresis once the patient is hemodynamically stable. And if the patient is a severe COPD, give him a bronchodilator. For any infection, give antibiotic and take culture from the source of infection. Common weaning problem, starting with the drowsiness. The patient may show good respiratory parameters when awake, but become apneic, pericardic, or hypotensive when they sleep. In this case, we will titrate opioid carefully. If the patient agitated, awake, the patient may be during the extubation, he will bite the endotracheal tube. This will cause hypoxia, coughing, and gagging, which is caused in raised intrathoracic pressure, which is lead to sudden increase in central venous pressure and decrease in mean arterial pressure, this may mimic the cardiac tamponade. In this case, if the patient very agitated, we can resedate the patient, ventilate him, or paralyze him if there is no improvement with any ventilation or resedation. Pulmonary, one of the common weaning problem is pulmonary dysfunction, which is maximally occur within 24 hours after extubation and normally improve within the first week following the surgery. Some factors will cause change in pulmonary function can be classified as preoperative, which include smoking, recent respiratory infection, old age if the patient more than 75 years old, obesity, if the patient very obese, will increase risk for atelectasis post-operatively and pulmonary hypertension. Regarding the intraoperative causes, median sternotomy, usually associated with decreased lung capacities. In a case of thoracotomy, this will increase lung injury. In a case of selective lung ventilation. Acid-base balance, as we discussed in previous session, we will start by looking for the pH if there is any acidosis or alkalosis. We will look at the carbon dioxide and we will check the anion gap. If the patient has metabolic acidosis, it may be caused by lactic acid, such as increase in metabolic acidosis, such as lactic acid, uric acid, and ketones in a case of diabetes mellitus or diabetic ketoacidosis. Drugs such as sodium nitrates overdose. These causes will cause cause the metabolic acidosis. In a case of low bicarbonate and hyperchloremic increased anion gap, caused by renal tubular acidosis, diarrhea, and hyperchloremic acidosis. Secondly, we have metabolic alkalosis. It caused by loss of hydrogen anions from the guts in a case of vomiting or nasogastric tube. Renal loss of hydrogen in a case of diuretics, or increased reabsorption of bicarb in a case of hyperchloremia. Administration of bases such as citrate in a blood transfusion. Respiratory acidosis, the respiratory failure caused by respiratory failure or hyperventilation, increasing in carbon dioxide production in a case of sepsis or malignant hyperpyrexia, and reabsorption of carbon dioxide in a case of citrus microcirculation. In a case of respiratory alkalosis, it may be caused by hyperventilation. The renal management, all cardiac surgical patients are catheterized with for urine output measurement and recorded hourly. The total fluid balance is calculated as well hourly. Serum electrolyte, once the patient arrives to the ICU, it should be checked, and every 6 to 12 hours will be checked hourly. Also, serum potassium will be checked hourly. The aim of a fluid management is to ensure adequate intravascular volume to maintain perfusion. The glomerular filtration rate and urine output is a sensitive measurement of cardiac function. Patient with a normal preoperative renal function should maintain diuresis at least 1 ml per kg per hour. Sometimes patients may experience excessive urine output. We should consider about diuretic administration, hyperglycemia, and normal ventricular function. To manage patients with a decreased urine output, first of all, check the Foley catheter if it is patent or no. If the patient if he is hypotensive, treat the cause first of hypotension. Give a fluid challenge of crystalloid and colloid to raise the central venous pressure to at least 14 millimeter mercury. Assessment of neurological function and management. First, start with assessing the pupil size. Afferent and efferent reflexes are usually checked after admission to the ICU and at least 3-hour interval. Before extubation, patient should be alert and oriented, but if the cognitive function is significantly impaired, Resedation and ongoing ventilation are necessary to identify and treat the underlying issue. The following assessments are made once the patient admitted to the ICU for every 4 hours in the first 24 hours, and then every 12 hours in the second day. We will check for eye opening, if it is open, spontaneous, or to the speech, to the pain, or not open at all. The movement, if the patient obeys commands or has weakness. The power of all limbs, upper and lower. If the patient have comprehensive and oriented to the yes and no question. If the patient sense of main determinants, and we will check the pupil size and reaction to the light. Regarding the mediastinal drainage and the pleural drainage is recorded hourly and ensured that the crucial quantity of the quantify the chest tube drainage and ensure that the tube is patent, as clotting a tube or blood in the open pleural space can mask ongoing hemorrhage. When the patients are moved, they may drain significant blood that has accumulated, which could indicate acute bleeding necessitate surgical exploration. The dark blood with minimal drainage suggests lack of active bleeding, and serial chest X-ray may help us to identify the residual blood. Regarding the active bleeding, is defined as a persistent bleeding exceeding more than 200 ml per hour for several hours, typically require intervention. To manage mediastinal bleeding, start with explore early for significant ongoing bleeding or tamponade. Ensure that the chest tube are patent. If it's not, try to milk out the tube to remove any clots. Warm patient to normothermia because the hypothermia produces generalized suppression for coagulation mechanism and impairment for platelet function. Try to control the hypertension with a beta blocker or vasodilation. Check the results for coagulation studies such as INR, prothrombin time, a platelet count, and fibrinogen level. Try to correct the ionized calcium to be more than 1.1 millimole, and give protamine, which is elevate the PTT. Use blood component to treat early significant bleeding from suspected coagulopathy, because persistent bleeding causes progressive depletion of clotting factor and platelets. Desmopressin, if there is any suspicion of platelet dysfunction from uremia or aspirin, von Willebrand factor deficiency may help us to reduce the bleeding. Use the transesophageal echocardiography is a concern when the patient suspected to have tamponade. Urgent exploration for significant ongoing bleeding or tamponade, urgent or emergency for bleeding. Control for body temperature. Warming once the patient arrived to the ICU should be warmed from hypothermia to reach the body temperature 37 Celsius. Why the rewarming of the patient is important? Sorry. Why the control of the body temperature is important? Because hypothermia can lead to atrial and ventricular arrhythmia, peripheral vasoconstriction, and increased systemic vascular resistance. It may cause to platelet dysfunction and impairment of coagulation. Hypothermia can increase the risk of infection due to immunocompromise. Post-ICU care, it involves comprehensive monitoring, pain management, respiratory care, and psychological support, and multidisciplinary approach, which is essential to facilitate recovery and prevent complication. Most of the patients are transferred to immediate care unit or cardiac surgery floor in the after 2 to 3 days of operation. Invasive monitoring in the same to the ICU monitoring will be discontinued. But however, bedside telemetry is recommended for several days to monitor arrhythmia. Patients are still in early recovery phase with various physiological demarked present. Discharge planning for the patient. As the hospital stay shortened, the effective discharge planning is crucial for smooth recovery. Patient may need temporary care at rehabilitation facility before returning home. Discharge planning is done by multidisciplinary involvement. It's involved the patient himself, the family of the patient, dietitian, nurse, and physician. Patient need a clear instruction about the recovery, expecting warning sign, and when to contact health providers. Patient should follow up in the surgical OPD within 30 days post-operative to monitor outcomes. Medication management for the patient. Patient should receive detailed medication list, including the needs of the medication and potential side effect of the medication and instruction regarding the medication. Patient also will need dietary guidance and lifestyle modification and activity restriction. Thank you for listening. This was my presentation. If you have any question, I'm ready for it. Thank you.
Thank you, Nora. That was a nice summary for the management and different aspects in the management for our patient for cardiac surgery. Any question or comments from the group before moving to the third lecture? Okay, we can have time for the discussion and comments after the third lecture. You can now participate in the survey for the second lecture. And Dr. Noor, you can prepare your slides. We'll start the third lecture at 2:45 p.m. You can start to turn on your talk whenever you're ready.
Our second topic third topic, inshallah, for today, we have a late complication of cardiac surgery. During this presentation, we will talk about the most common late complication following cardiac surgery, which include cardiovascular complications, valve surgery complication, neurological complication, infection complication, renal complication, and gastrointestinal complication. While the immediate post-operative outcomes are closely monitored, late complication can emerge during weeks, months, and even years after surgery. These complications can significantly impact the patient quality of life, and long-term complication and understanding them is crucial for us as a clinician and physician to provide comprehensive care of the patient. Starting with the chest pain. Chest pain is a common after cardiac surgery, and normally it reflects the effect of median sternotomy, rib retraction, and drains. Taking careful history from the patient should help us to differentiate between the causes of chest discomfort or chest pain. If the history gives us a dull sternal ache pain, it may indicate myocardial ischemia, cardiac tamponade, pericarditis, and peptic ulcer disease. If the pain comes with a movement, it may indicate musculoskeletal pain or wound infection or unstable sternum. If the pain is a pleuritic pain, it may indicate chest infection, pneumothorax, pulmonary embolism. After taking a careful history and examining the patient, especially if the patient has history of peptic ulcer disease, we have to check the drug chart for non-steroid anti-inflammatory drug usage. Chest X-ray will help us to demonstrate lung pathology. 12-lead ECG definitely will identify the myocardial ischemia or pericarditis. Transesophageal echo for persistent chest comfort that neither ischemic or musculoskeletal in origin, and exclude late cardiac tamponade. Chest CT will help us to identify the mediastinitis if the patient has other evidence of infection. Myocardial ischemia, a presentation of late myocardial ischemia after cardiac surgery may be due to many factors. It may be due to incomplete revascularization, early graft occlusion, vasospasm, and arterial conduits. Trauma to native coronaries at annulus during annulus valve surgery or near it. Hypotension, arrhythmia, and perfused anemia or hypoxemia. To diagnose myocardial ischemia, starting as well by taking a careful history, the characteristic of pain will help us to identify the cause. 12-lead ECG, as I mentioned in the previous slide, it will help to confirm myocardial ischemia and check for the cardiac enzyme such as creatine, CKMB, and troponin I, troponin T. They may often raised after the surgery, but serial measurement of the cardiac enzyme will show continuous or large raise. It may indicate myocardial ischemia. The definitive investigation in a cardiac ischemia is a cardiac catheterization to identify the coronary obstruction. Management for myocardial ischemia, patient with a poor native vessels, where he underwent percutaneous coronary intervention. Medical treatment will play important role in this problem. in a case patient with a normal coronaries who underwent valve replacement, or patient with underwent coronary artery bypass grafting with ongoing ischemia should be managed in ICU or as ICU management. Start with aspirin and ensure that the radial artery graft or total arterial revascularization are given, and give calcium channel blockers. Consider restarting preoperative anti-anginal medication, and furthermore discuss indication for angiography with a cardiologist. Atrial fibrillation, it's happened in each patient from 3 patients after cardiac surgery. The risk factor for atrial fibrillation is age. In older patients, they have more risk for atrial fibrillation, preoperative atrial fibrillation, hypokalemia, beta blocker withdrawal, inotropes, especially dopamine and dobutamine. Digoxin toxicity can cause fast atrial fibrillation. Sepsis and a chest infection. To manage patient with atrial fibrillation, assess the patient if hemodynamically stable and he's conscious, staying on the bed comfortable. Assure the patient. But if the patient hemodynamically compromised because of fast rate, hypertrophic left ventricle followed aortic valve replacement, organized direct current cardioversion, and treat the patient with potassium chloride through the central line to make the serum potassium 4.5 to 5. Treat the patient with magnesium sulfate through central line empirically, and restart beta blocker it has been stopped. Even if the blood pressure high, give amiodarone over 1 hour through central line followed by oral dose. If the left ventricle, if there's a left ventricle function, give digoxin over 30 minutes until the rate is controlled. But if there is no central access, give potassium orally and give magnesium sulfate orally. If the patient has a long state of atrial fibrillation and cardioversion is unlikely, digoxin may help gain rate control. And if the patient in atrial fibrillation should be in low molecular weight heparin and aspirin to prevent formation of mural thrombi or stroke or pulmonary embolism. Atrial fibrillation refractory to medical therapy. Patients have 5-fold to increase the incidence of neurological event post-operatively. 15% of the patient in atrial fibrillation has been shown by transesophageal echo to develop mural thrombi within 48 hours. Long-term rewarfarinization is associated with the incidence of intracranial hemorrhage. Constant atrial fibrillation for more than 36 hours but less than 72 hours, despite optimal medical treatment, they should undergo cardioversion under transesophageal echo guidance. Constant atrial fibrillation for over than 72 hours but not being anticoagulant should be sent home with a warfarin with a target INR 2 to 2.5 and reduced dose of amiodarone, and review the patient in the clinic at 6 weeks. Causes of, now we will discuss bradyarrhythmias. Causes of bradycardia after cardiac surgery may be caused by medications such as beta blocker, calcium channel blocker, amiodarone, and digoxin. Heart block, partial post-valve replacement, patient with a normal restarting rate in a fit patient, young and tall patient, and hypoxia. Management for bradyarrhythmia, we start with assessing the patient. If emergency, give atropine and do 12 lead ECG to exclude any heart block and ischemia. Late cardiac tamponade. Some patients have pericardial effusion post-op, which is normally resolved without causing cardiac tamponade. But in a 5% of the patient, these effusions increase in size and may cause tamponade. The causes include intrapericardial bleeding following removal of the pacing wire, coagulopathy, and anticoagulant. Serous effusion due to hypovolemia or post-myocardectomy pericarditis. To diagnose patient will present with ill-defined symptoms, but it may present with malaise, lethargy, chest comfort, and anorexia, or with or without those clinical findings. Progressive hypotension and tachycardia, raise in jugular venous pressure, pulses, paradoxes, and increase peripheral edema. It may increase the creatinine and decrease urine output. It may show by chest X-ray and confirmed by urgent transesophageal echo. Muffled heart sound and pericardial rub are often non-specific for a cardiac tamponade, but the definitive management is urgent pericardiocentesis. Infective endocarditis is complicated, and 0.2 to 0.5% of mechanical valve replacement within 30 days of surgery, and 2% after 5 years. The figure for tissue valve is similar to mechanical valve, but it's slightly less than during the first 30 days. Blood culture should be taken if any valve patient with a temperature more than 36.5 for more than 3 days post-op. Standard advice regarding antibiotics should be started from day one, not just following the discharge of the patient. Any potential source of bacteremia, such as urinary catheter, central line, should be treated aggressively. Paraprocentic valve leakage, it occurs in about 2% of aortic valve replacement and 1% in mitral valve replacement. Paraprocentic leak within 30 days of surgery are usually either the result of swing ring being poorly seated within calcified irregular annulus, or the result of suture cutting out from the annulus. The late paravalvular leak are usually associated with endocarditis, which is a case. In this case, they almost inevitably require surgical repair after treatment with antibiotic. High velocity paravalvular leak may cause hemolysis, severe enough to be indicated for valve replacement. If the patient neither have hemolysis or infective endocarditis, the management will be paravalvular, depend on the degree of hemodynamic compromise here. Prosthesis failure, which is a structure problem not associated with thrombosis, endocarditis, hemolysis, or hemorrhage, may necessitate valve replacement. Structural failure of mechanical valve is rare. Biprosthesis lasts longer than the aortic position and in older patients than the mitral position in a younger patient. Patients are should be reviewed yearly, either by the cardiologist or by us, with the transesophageal echo to identify and monitor the valve failure. The indication for surgery for structure failure of biprosthetic are similar with a native valve. Bleeding and thromboembolism. Thromboembolism events include transient ischemic attack or stroke. Valve thrombosis is obstruction of the mechanism of the proteases due to thrombus. In 95% of the cases of valve thrombosis, therefore, occur in mechanical valve. But the patient with mechanical valve have a higher stroke risk because there is a risk of major hemorrhagic event, including stroke, which is associated with anticoagulation. Valve thrombosis is most commonly due to an inadequate anticoagulant because poor compliance, change in either medication or illness. Smaller aortic valve has a higher risk than the larger valve. A patient with a procentric valve thrombosis may present with angina, pulmonary edema, poor peripheral perfusion and systemic embolization, and acute hemodynamic compromise. Transesophageal echo, fluoroscopy, or CT may be needed to show failure of one or both leaflet to open. If the thrombi less than 5 mm, they are not obstruction in the valve orifices or mechanism may be treated with formal anticoagulation alone. Stroke. The incidence of a stroke in a cardiac surgery patient is 1 to 2% for CABG. For valve replacement or repair is 2 to 3%. The patient with one or more risk factor has much higher incidence to have a stroke, which is affect the consent and operation planning. Risk factors will be included if the age of the patient more than 8 years, the risk will increase. Diabetic patient has higher risk to have stroke. Previous history of stroke or transient ischemic attack will increase the risk of stroke threefold. Carotid artery atherosclerosis, preoperative hypertension, calcified or very atherosclerotic ascending aorta, calcified aortic or mitral valve, left-sided mural thrombus, and long-standing of cardiopulmonary bypass, post-operative atrial fibrillation, and failure to give antiplatelet therapy post-op. Clinical features of stroke. Most of the neurological deficits appear once the sedation has been weaned, usually within 24 hours, but 1/3 of the patient, the stroke will occur after several days post-op. Any deficient resolving within 24 hours will call transient ischemic attack. Clinical feature of a stroke will include failure to regain consciousness once sedation has been weaned, hemiplegia due to middle cerebral artery or total arterial artery occlusion. Initial areflexia become hyperreflexia and rigidity after few days. Asphyxia, ataxia, and inadequate gag reflex and aspiration, and visual deficient unilateral neglection and confusion. To diagnose, the aim to establish definitive diagnosis and establish the cause, guide appropriate secondary prevention, and establish baseline of function to help planning for long-term rehabilitation or withdrawal of the therapy. Start with a carry out full neurological examination. It include cognitive, functional, and cranial nerve examination, tone, power, and reflexes, and sensation of all 4 limbs. Contrast CT of the head will show infraction within 2 hours. Management for stroke. The initial management start with ABC, which is check the airway, check the breathing of the patient, and check for the circulation. If the patient is unable to maintain their airway, insert Godel airway, give a bag and mask ventilation with 100% of oxygen, and call the anesthesia. Monitor the blood pressure, but do not attempt to correct the high pressure, as they are crucial for adequate cerebral perfusion. Monitor the oxygen saturation. Make sure that to rescue IV access and give colloid if indicated. If the patient is able to maintain their own airway and not hemodynamic compromise, explain to the patient what exactly has happened. Perform a full neurological examination and put the patient in NBO to prevent any aspiration, and if the patient has no gag reflex. Send complete blood count and chemistry and coagulation. Send blood culture if there is any history of endocarditis or pyrexia. Do a 12-lead ECG to identify if the patient has atrial fibrillation, heart block, or other causative problem. Send the patient for urgent CT head to identify any emboli or hemorrhage. Unless there is a strong suspicion that the stroke is hemorrhagic, give aspirin and continue if the patient already in aspirin. Long-term management of stroke. It's come with medical treatment. Cardiothoracic patients are not candidates for thrombolysis. Recent major surgery is one of the exclusion criteria. Aspirin reduces death and dependency for the patient. Warfarin and heparin will reduce recurrence, embolic, and stroke if the patient has atrial fibrillation. Patient with a severe stroke may need intubation and ventilation for respiratory failure, and try to send the patient for swallow assessment. Prevention of a stroke. Start with a carotid endarterectomy. The single most important preoperative intervention is identify significant carotid disease. All patients with a previous history of stroke or transient ischemic attack or with the carotid root should undergo carotid Doppler. Patient with a stenosis. If the patient has a stenosis less than 75%, has higher risk for stroke with a carotid endarterectomy than the patient who has cardiac surgery alone, and their carotid disease should be lifted. Patient with a stenosis more than 75% but less than 99% of their internal carotid artery and history of transient ischemic attack or stroke have a lower risk of stroke if they undergo carotid endarterectomy. Try to maintain mean arterial pressure 80 mm mercury if in patient at risk for ischemic stroke, and do selection cannulation site which can be guided intraoperative ultrasound of ascending aorta. Meticulous removal of debris from operative field. Peripheral nerve injury. Starting with a brachial plexus injury, this is caused indirectly by sternal retraction and directly caused by trauma when placing central line. If it presents as paresthesia and weakness in the forearm and hand. The pharma diagnosis done by electromyography study, and it can be avoided by placing a sternal retractor and try to be more cuddly and possible to open slowly. Treatment, usually physiotherapy with referral to pain services for chronic pain, which is unresponsive to analgesia. Horner syndrome, which is characterized by ptosis, meiosis, and hydrosis, which is result from damage of sympathetic nerve supply to the eye. inadvertent damage during central line replacement, carotid endarterectomy, harvesting very proximal internal mammary artery, and stroke may cause this syndrome. Treatment for Horner syndrome is symptomatic. Recurrent laryngeal nerve palsy. This may occur as a result of internal mammary harvesting, trauma of the arch of the aorta, for example, during cannulation, trauma to the neck from internal jugular vein cannulation, or pressure injury from the malpositioning of the endotracheal cuff, and may caused by cold injury. The patient will present with a hoarseness, breathlessness after extubation. To manage this patient, the patient should be seen by ENT surgeon. Respiratory complications, starting with the chest infection. The incidence of pneumonia after cardiac surgery varies from 2% and reach to 20%. The diagnosis, starting with a history of cough with purulent sputum or a purulent secretion, aspiration from endotracheal tube. Patient will have also pyrexia, bronchial breathing sound, reduced air entry. Laboratory will show leukocytes, neutrophils raised in a CRB, sputum culture, and may yield sensitivity to causative organism. Chest X-ray will show us a sign of consolidation and will confirm our diagnosis. To manage the patient with a chest infection, the most important intervention to prevent patient with an active chest infection undergoing surgery is a physiotherapy, which is help the patient and preventing mucus plugging. Effective analgesia is important to allow patient to cough, take blood culture sputum, and give empiric antibiotic until the results come. The hypoxic tachypneic patient should be maximally supported, respiratory supported. Vocal cord prolapse. The incidence after cardiac surgery is probably about 1% to 2%. Patient will present with a hoarseness, breathlessness, difficulty to phonate, and difficulty to cough after drinking. These patients should be placed in BO to minimize the risk of aspiration pneumonia, and should be reviewed by ENT surgeon and undergo to speech and swallow assessment. Pleural effusion. Up to 40% of the patient undergoing cardiac surgery will develop pleural effusion, which may be unilateral or bilateral. Internal mammary harvesting is associated with a higher rate of ipsilateral pleural effusion. To diagnose pleural effusion, it's often asymptomatic, but the patient may present with dyspnea, pleuritic chest pain, decreased air entry, and dullness in percussion. It may be difficult to distinguish between consolidation and effusion on chest X-ray, but the meniscus is suggestive of pleural effusion and air fluid level diagnosed in hydropneumothorax. Management of pleural effusion. If pleural effusion is small, it can be treated with increased diuretics such as furosemide. If the pleural effusion is large, more than 3 to 4 centimeters by ultrasound, should be drained with a big tail catheter. But you have to leave the drain until the suction is less than 100 milli in 24 hours. Renal complications, starting with acute renal failure, patient with elevated creatinine and urea and who have returned to the ward should be daily checked for serum electrolyte and renal marker. Start with insertion of urinary catheter and comment hourly for fluid balance chart. Recheck the medication and stop any nephrotoxic drugs such as angiotensin converting enzyme inhibitors and non-steroid anti-inflammatory drugs and antibiotics such as gentamicin. Active look for the exclude relative hypotension, hypovolemia, sepsis, and delayed cardiac tamponade. If the patient is hypovolemic, stop any diuretics therapy and hydrate the patient carefully. Gastrointestinal complication, starting with paralytic ileus, which is occur up to 5% of the patient after cardiac surgery. It may share a feature with small bowel obstruction, including nausea, vomiting, constipation, and absence of bowel sound, and dilated loop in gas-filled bowel and abdominal film. Usually, the patient is pain-free and passing flatus. The possible cause including gastric distension from ineffective bag and mask ventilation or CBAB, mesenteric ischemia, venous congestion, and pseudomembranous colitis. Drug, especially the opioids, and other GI pathology, including peptic ulceration and pancreatitis. To manage patients with paralytic ileus, start with a passing nasogastric tube to decompress the stomach and consider flatus enema. Stop any opioids and contributing drug and try to mobilize the patient as possible. Keep the patient in BO and with normal saline. Prolonged ileus or pseudo obstruction may necessitate colonoscopy. Upper GI bleeding is most commonly caused by peptic ulcer disease and occasionally trauma to the esophagus or oropharynx from intubation with a nasogastric tube or transesophageal probe. Peptic ulceration risk after cardiac surgery is increased by stress major surgery. The diagnosis of the patient may have hematemesis, may be seen by the nasogastric tube. Patient will have melena or positive fecal occult blood test. Patient will have abdominal pain, peritonism, hypotension, and tachycardia. And will in lab result, we will see drop in hemoglobin. Prophylaxis of upper GI bleeding. Give the patient omeprazole as prophylactic. If the patient has a history of peptic ulcer, gastritis, or hiatus hernia. Start nasogastric feeding patient with a fail of extubation early and avoid using non-steroid anti-inflammatory medication in a patient with who has history of dyspepsia or old age patient. Lower GI bleeding is characterized by fresh rectal blood, but may require passage of nasogastric tube or to exclude upper GI sources. The common causes is mesenteric ischemia, infective colitis, and bleeding from colonic polyps. Mesenteric angiography may be necessary to identify the lesion before surgical resection. Mesenteric ischemia may be caused by global hyperperfusion due to low cardiac output state, high doses of pressors, atherosclerotic embolism, and thromboembolism. It is present in the ICU as worsening metabolic acidosis, failure to absorb nasogastric feeds, and abdominal distension. Awake patient may complain of severe abdominal pain, nausea, and vomiting, and diarrhea, which is initially seemed like bloody diarrhea. Diagnosis on a clinical grounds is difficult in ventilated patients, but contrast CT or angiography is useful. The definitive management of mesenteric ischemia is laparotomy and resection of infracted segment. Hepatic failure, approximately 10% of the patient will develop mild hepatic dysfunction after cardiac surgery with a transient rise in liver enzyme and bilirubin. Permanent hepatic failure, which is complicated less than 0.1% of cardiac surgery patient with no history of preoperative hepatic dysfunction, has mortality rate 8%. The etiology of hepatic failure, preoperative dysfunction, such as in a case of hepatitis, cirrhosis, or biliary obstruction, hemolysis in blood transfusion, hematoma, or G6PD, or excessive use of pump sucker, or prolonged bypass. Hepatocellular injury, low cardiac output state, right heart failure, and hepatotoxic medication will associate with it, especially the acetaminophen medication. Management of hepatic failure, try to reduce hepatotoxic medication is usually required. Management of permanent hepatic failure is mostly supportive. Try to check the blood glucose frequently and replace as indicated. Cardiovascular support required for pulmonary artery catheter insertion and stroke. Give empiric antibiotic prophylaxis. Wound infection, start with deep, sorry for this mistake, deep internal wound infection. Infection in the tissue deep to the subcutaneous layer and either positive culture or microscopic histological evidence. Symptomatic patient and pus, up to 75% of wound infection present after discharge from the hospital. The incidence is frequently under-reported. The risk factor will include, starting with a preoperative risk factor, old age patient, diabetic patient, obese patient, and smoking will increase the risk of wound infection. Operative risk factors include paramedian sternotomy, bilateral harvesting of the mammary artery, prolonged surgery, and poor surgical technique, which include excessive use of the wax, excessive use of the cautery, and wrong placement of the sternal wires, and poor aseptic techniques. Post-operative risk factors include G-sternotomy for bleeding, multiple transfusion, and mediastinal bleeding, prolonged ventilation, and impairment of the nutrition. To diagnose the patient, patient will have fever, blood culture will be positive, sternal will be unstable during examination, and patient may complain of this issue. Serous or purulent discharge and wound dehiscence, pericardial effusion, and chest X-ray may show marginal sternal wire or fractured sternum. CT will show us evidence of non-union pus and osteomyelitis. To manage the patient, a cuff lock may reduce the pain for the patient and reduce impact of a dehiscence. Give the patient IV antibiotic, put the patient on a vacuum dressing. If necessary, we will do surgical debridement and rewiring for the sternum. Rewiring of the sternal wound, patient may have a multiple organ dysfunction as a residual of sepsis, tissue friable, and surgery often take place at a time when adhesion are maximal 4 to 6 weeks after surgery. Ensure that the patient has appropriate antibiotic induction. All pus is evacuated from pericardium and being great care of anastomosing line. Send the pus and bone culture to guide us to the treatment. If the sternal is unstable and dehiscent, is usually due to poor surgical technique. Sternal wire through becomes soft and osteoporotic sternum. The incidence is 1 to 2%, and the patient complains of excessive costochondrial pain and the clicking on movement. And instability may be palpated when the patient is coughing. This may be managed either conservatively or prophylactic antibiotic and supporting dressing, with or without elective sternal rewiring. Hypertrophic and colloid scar, mediastinal incision have a tendency to form raised hypertrophic scar. Colloid scar are common in a patient who's African American. There is no known specific evidence to avoid this problem, apart from attempting to minimize the length of sternotomy incision and considering submammary incision. Topical silicone gel dressing worn up to 24 hours per day for several months will be reduce the prominence of hypertrophic scar, but they can replace when the dressing are abundant. Colloid scar are not a response to surgical excision, but we may refer the patient to plastic surgeon if indicated and the patient is unhappy with his cosmetic result. Steroid injection may offer some improvement for the scar. Sternal wires, sometimes the patient will complain of prominent sternal wire. This is commonest in a very thin patient. If there is a sternal instability, sternal wire may be removed and should be done under general anesthesia, of course, with appropriate and invasive monitoring. Even if the simple removal of sternal wire may return to an expected resternotomy. If the patient is unhappy with his sternal wire, before doing the fixation, and we can plan with this patient the places of sternal wire he's unhappy with, and it can be removed through stab incision. Thank you for your listening. If you have any question, let me know.
All right, thank you, Nora, again. That was a nice summary and overview for the complications after cardiac surgery. Any questions or comments from the group before moving to the quiz? Okay, since there is no questions or comments from the group, now we can move to the quiz part for the second and third lecture together. And before that, I just want to emphasize about the importance of this topic and understanding how unique is the cardiac surgery from other surgery fields, especially with the use of cardiopulmonary bypass and its implication and the circulatory support and hemodynamics and the and the how does it provoke the inflammatory support and condition after surgery, and in order to prevent the complication, you need to understand the pathophysiology for the development of the different organ dysfunction after cardiac surgery. So if you identify high-risk group of patients, you can tailor your management strategy to prevent those complications from developing. And it's all about early diagnosis and treatment to prevent further deterioration and subsequent mortality and morbidity. We have total now of 16 questions. We'll have 10 minutes in total. Then we'll discuss them quickly, inshallah. Okay, you see now more than half of the group participated in the quiz. So we can go over the questions quickly and review them. Anyone wants to participate and volunteer to read the question?
أيوة خالد. طيب. So you have decided to do an all arterial bypass using the bilateral mammary and the radial artery. One significant factor in pre-operative and post-operative care is maintain blood pressure above 80, use of inotropes, use of calcium channel blockers, and use of or the use of apertinin. I chose calcium channel blocker, and ما أدري خالد, what is the practice in your center? Because we didn't do all arterial actually. It's not our routine, but we have done it before. Where I noticed that some centers are giving the calcium channel blocker post-op and they continue for 6 months. And some of them they are saying 1 year after the all arterial bypass. So what do you think about this?
Okay, thank you, Ayat. Yes, the correct answer is the use of calcium channel blockers. We're mainly interested here in the scenario for the radial artery and the prevention of the vasospasm being highly vasoactive conjugate. The common practice we see starting actually from the intraoperative, from the preparation and the radial artery solution, continuing to the either immediate post-op. The hemodynamics allows for an infusion of a vasodilator, either nitro or starting a calcium channel blocker orally. And the common practice we see is for the at least for the first 6 months to 1 year.
Great.
Anybody else want to volunteer and move to the second question? It's a straightforward one.
Yes, Khalid.
أهلا. Go ahead.
Which organism most commonly isolated in patients with deep sternal wound infection? The correct answer is Staph aureus.
That's true. Actually, many references, the commonest isolated organism is reported as a Staph aureus. Next, please, anyone?
Yes.
Go ahead.
Actually, is the question once I open my mic, the question is not appearing. But I believe that the correct answer is non-hemolytic transfusion reaction as the last answer.
Okay, the question was which of the following complications most common after post-op blood transfusion? And yes, as you mentioned, the commonest is the non-hemolytic febrile reaction. Next question, anybody wants to volunteer?
الأذان والدعاء.
Go ahead, please, anyone.
Yeah, Khalid. So the question was, which of these does not result in low mixed venous saturation? Is it the decreased CO, anemia, hypoxia, or septic shock? And the answer was the septic shock. But it's not the decrease in the, it's not, it does not result in low mixed venous.
Yes, that's true. Actually, septic shock does result in high mixed venous saturation.
Yeah.
I see 39% got that answer correct, and 39% got the first answer, the first choice, decreased cardiac output, as the proposed answer for this scenario. Nearly half of them. So the concept for mixed venous saturation, it does represent the difference between the oxygen delivery and the oxygen consumption by the tissue. And we refer mixed venous saturation as an indirect assessment or measure for the cardiac output. So low venous sat, either with decreased delivery or increased consumption. So with low cardiac output, of course, we have low oxygen delivery. And with anemia also, we have low oxygen delivery. And with hypoxia, also low oxygen delivery. So all those answers, they cause low mixed venous sat. But in case of septic shock, due to decreased oxygen consumption and extraction by the tissues, secondary to sepsis and septic shock and vasodilatation, so we'll have a high mixed venous sat. I hope that makes sense for everyone.
Yeah, it does.
بس النقطة الأخيرة إذا قلت in septic shock you have increased oxygen consumption.
Yes, we have decreased oxygen consumption and extraction with the sepsis and vasodilatation. So usually with sepsis, we see high mixed venous saturation.
So how do you explain that, the decrease in oxygen consumption, and how do you explain the greater mixed venous numbers?
The increase in the consumption of oxygen and
Increase or decrease?
in the septic shock.
Yes.
It does increase in the it does increase the consumption of the oxygen because the tissue is now deprived of oxygen.
So if it's deprived, you mean not receiving oxygen? How can you say it's increasing in the consumption? Walid, maybe you can answer this. Why do you think the oxygen saturation is higher? The venous oxygen, mixed venous saturation is higher in those patients. Okay, so the principle. Go ahead, Walid. If you want to try, go ahead.
Well, that was new information to me, but maybe I can justify it by the vasodilation. With vasodilation, you'll have inappropriate transfer of oxygen in tissues.
Okay, so in the pathophysiology of this disease, if you look at what happened to the circulation, there is the pre-capillary sphincters are basically shunting all the blood away from the capillary into the venules. So what happens is that the oxygenated blood will come, but not going to the tissue. It will go through the shunt back into the venous system. And that's why you have higher saturation in the mixed venous. By the same token, the tissues is deprived. So they do want to have oxygen, but they cannot extract it because it's not reaching them. So actually there is a decrease. There is a decrease in oxygen consumption because of the delivery at the level of the capillaries is decreased.
Yes. Yeah.
Okay, so and that's why you also have lactic acidosis, because all the tissues now are basically using anaerobic metabolism to survive. And you will have higher production of lactate, which will not go into the Krebs cycle and will not give you the better energy source. At the same time, it will accumulate a lot of lactate. Does that make sense?
Yes, it does.
Okay, and the hypotension associated, the increased cardiac output associated with this is due to the shunt of the blood from the arterioles into the venules away from the capillary. So that will give you basically low resistance leak away from the tissues. And that can give you hypotension, and it can give you increased cardiac output because of this shunt. Okay, well, thank you.
Thank you, Dr. Farid, for a nice illustration. Okay, we can move to the next question. Any volunteer?
Okay, I can read. Which of the following statements is false in regards of phrenic nerve injury? Left side is the most common site to be injured. Most commonly injured during aortic arch surgeries. Most patients with unilateral phrenic nerve paresis have fused respiratory symptoms and are extubated, and eventually diaphragmatic fluoroscopy could confirm the diagnosis. So left side is the most common site to be injured. It's not true. This is true. Sorry. The question is, what is false? So most commonly injured during aortic arch, or the third option is correct also. Most patients with unilateral phrenic nerve paresis have few respiratory symptoms and are extubated, and eventually with unilateral. Yeah, that's true. Diaphragmatic fluoroscopy could confirm the diagnosis. Yes, that's true. So it's commonly injured during aortic arch surgery is not true.
Okay, that's right. The question asking about the false statement, which is the second answer, most commonly injured during aortic arch surgery, and we'll have another scenario on this. Moving to the next question. Anyone else wants to participate?
Khalid?
Go ahead, sure.
After open heart surgery, it's noted that the patient has lost his atrial kick. What amount of ventricular contraction is usually lost in the absence of an atrial kick? So I remember it was like around 25%. So it should be 20 to 30% the correct answer.
Well, that's true. You know how the atrial contraction is important for an effective cardiac output. It does contribute to nearly 20 to 30%, or roughly 25% of the cardiac output.
Yeah.
This is lost for sure in various disorders like in atrial fibrillation or in AV block post surgery. Okay, moving to the next question. Can see 100% got that answer right.
I can participate.
Yes, please go ahead.
Okay, so the question. Okay. A 2-year-old undergoes patent ductus arteriosus ligation. Surgery is uneventful, but soon after surgery, the child is found to have a voice problem. What is the most likely cause of this complication? A damage to the recurrent laryngeal nerve. And this is because on the left side, it passes in front of the arch. Okay. And then wraps underneath and behind it. And it's most probably the cause. Hello?
So you can see percent get that answer true, which is a damage to a recurrent laryngeal nerve. And of course, it's an anatomical landmark and a marker for the location of the ductus. And as you mentioned, it originates from the vagus and it loops posteriorly around the ductus and the ascent behind the aorta. And this is commonly injured during the ductal ligation. Next question. Anyone would like to volunteer?
I can answer.
Yes, please.
Read.
Go ahead.
Which is not a feature of cardiac tamponade. So the A, C, and D are all correct, leaving B as the only correct answer. Explanation. Which is why. Explanation for it could be due to decreased systolic blood pressure, decreasing the pulse pressure, not widening it.
Yes, so usually cardiac tamponade associated with hypotension, high JVP, and muffled heart sound, distant heart sound, low voltage KRS, and the pulse pressure tends to be narrow pulse pressure, not a wide pulse pressure. As you mentioned, thank you. Next question, general surgery question.
I can answer.
Yes, go ahead, please, Nora.
Fever in the first 24 hours after surgery is usually due to which of the following? In regards of post-op fever in the first 24 hours, atelectasis is the most common cause.
Right, that's true. People in the first 24 to 48 hours is usually atelectasis. Next question, please.
Okay. So the question is about the LVAD. Just a second. Yeah. Which of the following is not a complication of LVAD placement and management? Is it a driveline infection, stroke, acquired von Willebrand syndrome, or LV failure? Driveline infection is common. Stroke is common. Or von Willebrand, yes, they do have acquired von Willebrand and abnormal. I remember it was like abnormal vasculature. After that, I forgot the term. And then RV failure might happen also. The LV failure, no, it's not true. let's say.
Okay, so most of the mentioned answer, right line stroke and acquired one-with syndrome, is actually a complication for LVAD, but the LV
Yes.
has heart failure with reduced ejection fraction. It's an indication for LVAD placement. It's not a complication.
Mhm. They have RV failure. They do have RV failure after the LVAD. Not, يعني, if it is RV, I would choose RV as a correct answer.
So, which is the biggest struggle after LVAD placement?
Mhm.
All of them then will be correct answers.
Mhm.
So, the next question, please. Any volunteer?
Shall I read it?
Go ahead, no, thank you.
A post-operative patient following a mitral valve leaf surgery has been complaining of shortness of breath. An echocardiogram reveals left ventricular diagnostic collapse. What is the next step? The next step would be a sub-xiphoid window, as left ventricular diastolic collapse is a sign of regional temperate.
مفترض right ventricle diastolic.
So in this scenario, we know that we're dealing with a tamponade, and the post-op tamponade, usually it's a clinical diagnosis. We don't need an echo to, sometimes we just ask for it to confirm the suspicion. But an echo, we can see large pericardial effusion, and actually both chamber collapse can happen, and also especially LV diastolic collapse. And the correct answer, as you mentioned, Nora, is the sub-xiphoid window. Next question, please.
I'll read.
All right, thank you. Go ahead.
Which of the following findings would help differentiate acute respiratory distress syndrome from cardiogenic pulmonary edema? Hypoxemia, bilateral infiltrate, decreased lung compliance, or pulmonary capillary wedge pressure. D. Hypoxemia would occur in both, as well as bilateral infiltrate. Decreased lung compliance is basically indicative of lung edema. Pulmonary capillary wedge pressure, increased pulmonary capillary wedge pressure indicates that there is an LV issue leading to the pulmonary edema rather than a lung issue.
All right, I see 30% get that answer correct, and you're right, as you mentioned, Walid. Having a high pulmonary capillary wedge pressure indicates an high LVDP and ventricular failure. So both conditions may have hypoxia or bilateral infiltrates, and also both conditions might present with decreased lung compliance, especially the ARDS patient. So in this scenario, having a high pulmonary capillary wedge pressure usually it indicates that we're dealing with cardiogenic pulmonary edema rather than ARDS. But some ARDS patients, they also might have a high pulmonary capillary wedge pressure reported in the literature around a third of those subset of patients. But just roughly to an idea to differentiate. Next question, anybody wants to volunteer?
Yeah, I can answer this.
Thank you, Hussein, go ahead.
Okay. Okay. After an uneventful cabbage, a patient reports a loss of sensation in the leg from which the vein graft was taken. Damage to which of the following nerves is the most likely explanation for this symptom? Saphenous vein is a saphenous nerve is the answer because of long saphenous vein, most likely vein harvested.
That's true. It's a pure anatomic question, which is a branch of the femoral nerve, but the commonly injured vein during saphenous vein harvest is the saphenous nerve. Okay, I think yes. Next question.
Okay.
Also wants to volunteer.
I would like to. So the question is about AVR. So following an AVR, second-degree heart block persists until the second post-op day. The treatment for this patient is continued observation, insert a permanent pacemaker, electrophysiological study, or take the patient to OR for replacement of epicardial electrodes. I chose observation. Actually, you notice that lots of patients post AVR, MVR, they would have heart block. So we continue observing them. It's just the second day, so you continue observing them for like 1, sometimes 2 weeks, and then you decide on them. So I will just continue observing the patient.
That's true. The correct answer is continued observation, as is the patient is still in the second post-op of the day. And usually our colleagues from electrophysiology would like to watch and wait until rhythm assessment beyond at least 5 to 7 days post-op. All right, moving to the next question before the last.
I will read it.
Go ahead, please.
A patient has an eventful coronary artery bypass graft. On post-operative day 1, the chest tube were removed. In follow-up, chest X-ray showed pneumopericardium. The patient has no hemodynamic disturbance. The best treatment is observation.
Okay, that's true. The pneumopericardium or pneumodiastema is actually symptomatic, and observation is the usual. Management for such patient, given that they don't have any hemodynamic components. Last question. Anyone would like to read an answer?
I can. An elderly female underwent a difficult mitral valve replacement. In the ICU, the chest tube output continues at 400 cc per hour for 4 hours. The next step is, so it's she's an elderly lady that was a difficult mitral valve replacement, and now she is bleeding from the chest tubes 400 cc per hour for 4 hours. So regarding the re-exploration, from STS book, you can say that the more than 400 ml per hour for 1 hour, this is an indication. More than 300 ml per hour for 2 to 3 hours, this is another indication. More than 200 ml per hour for 4 hours, this is an indication. In the case, it's 400 cc per hour for 4 hours. So it's an indication for re-exploration. So it increases mortality and morbidity, taking the patient back to OR. So we have to stick to the guidelines that we shouldn't take the patient, we shouldn't have like low threshold to take the patient back to OR unless we consume I mean, it's not an indication as per the guidelines, and also we consume the products, and we started the medical therapy because it does increase the morbidity and mortality.
All right, thank you, Ayat. So here in this scenario, we have a clear cutoff for post-op bleeding, surgical bleed, which is 400 cc per hour for 4 hours, which is mentioned in the general guidelines for exploration by the hourly bleeding rates, as Ayat mentioned. So the correct answer is the exploration for this patient. Okay, this was the end of the second quiz. Thank you all for participating. And thanks for our presenter. Thank you for Dr. Farid for being with us today.
Thank you so much.
Just before the conclude, we can move to the presenter survey as Dr. Wade about the survey now. You can participate and
Khalid, if you allow to me, I have just a small announcement for all R6 and 7. Please check your email and your WhatsApp, as there will be, inshallah, workshop for the senior residents for completion of registration for all R6 and 7. Thank you.